Thank you very much for joining us. Very excited to be here with you for this session on the racial health equity and social care meeting from Siren. And today, this is mainly the differential impacts of social care interventions, part 2. So first, I wanna introduce our team that's gonna be here today presenting. My name is Pablo Buitron de la Vega. I'm a primary care clinician. I work at Boston Medical Center and Boston University, and I do a lot of work in terms of screening and referral for health-related social needs. I'm very excited that also Sharon is here with us. Sharon, can you introduce yourself? Thank you.
Yeah, hey, my name is Sharon Alexander. I am what they called an expert by experience. I've just been a patient. I've been involved with the various entities, some of which Siren is one of them. I'm, happy to be in front of this group right now as the expert by experience. I'm not sure, is this my time to talk, or you just want to introduce everyone? I'm not clear on that.
Yeah, we'll do just introductions and then I'll pass it. Yeah.
Okay.
Thank you, Sharon.
Yes. Thank you.
Thank you. Yeah, so Sharon is bringing really the focus on the live experience, and she's going to share a little bit of what her impressions are from the presentations. And then we have our amazing panelists. So we are going to have 3 different presentations. First, we'll have Halima Ahmadi-Montecalvo. She's a senior director of research and evaluation at Unitas, where she leads evaluation efforts to measure the value of social care investments. That's going to be our first presentation. Then Natalie Tedford is currently a fellow in pediatric emergency medicine and global health at the University of Utah and Primary Children's Hospital. And then we're going to have a shared presentation presenting as a team. Mary Miller is the manager of 211 Innovation at United Way Worldview, and Rachel Garg, that is a PhD candidate in public health sciences at the Brown School at Washington University in St. Louis, and that analyst at the Health Communication Research Laboratory. So very excited to have our panelists here, and we're going to get started. First, let's quickly review the agreements for a safe and brave meeting. These are things that we strongly believe that need to happen so that we can share this space, that we can learn from each other, that we can collaborate, that we can have discussions. And I wanted to give you guys a minute to see this. I think the one that really resonates the most to me is really be curious about intentions, but recognize that impact is more important than intentions when you're sharing, when you're asking, when you're discussing, and that's very important here. There's 3 ways that you can engage in the room. One, remember the chat window. You can put your questions, you can put your comments, your reactions. Feel free to do that. Also, the emojis here with Zoom, we have these emojis in terms of reactions. If you love something, if something gets you excited about, you can use that as well as the audio and video. We will do the presentations first. Each presenter will have 10 minutes. Then Sharon is gonna share reactions to this, and then we'll go to answer some questions for the rest of the time. Excellent. So let's get started. So we're gonna start with our first presented. So Halima is gonna talk to us first, and she's gonna be sharing her presentation now. So I'll stop sharing my screen. Okay, we can see your screen now. I don't know if you're muted or not. Okay, there you go.
Okay, great. And you see my presenter screen? Yes, okay, great. Hi, everybody. My name is Halima Ahmadi-Montecalvo, and as Pablo mentioned, I lead the research and evaluation efforts at Unitas. I'm a social epidemiologist by training, and my work for the past couple of decades has revolved around health disparities research and evaluation of programs addressing health disparities and advancing health equity. And My agenda for today is really to briefly describe the role that Unitas plays in addressing health equity. I also would like to highlight some social need trends during the pandemic that we observed, and then also lessons learned from our data, and then wrap it up with a discussion on how we move forward. So for those of you unfamiliar with Unitas, we're a technology company that builds closed loop coordinated care networks, connecting health and social care providers through one system of record. Our platform provides the technology that's needed for secure, transparent, cross-sector collaboration to address whole person needs. I'll quickly walk through an example of how this works. In this case here, what you see on the screen, Tom shows up at Sue's organization looking for food assistance. Sue screens Tom using an SDOH assessment tool like Prepare or Health Leads to identify Tom's additional social needs. In this case, Tom needs food assistance, childcare support, and behavioral health support. Sue then logs into the Unitas platform, identifies community and healthcare providers, and after capturing Tom's consent, sends referrals to the identified organizations on behalf of Tom. So what happens here is that those organizations reach out directly to Tom, and all members of the care team are able to have visibility into Tom's journey, including any reported outcomes or resolutions. So moving on to sharing some notable observations with you all, during the first few months of the pandemic, it became clear that needs were shifting throughout communities, and they were shifting away from services that offer long-term benefits like employment, childcare support, and benefits navigation to more immediate basic needs like food, housing, utilities, payments. And what we saw in our networks was that volumes of referrals and assistance requests almost tripled within those first few weeks and months of the pandemic. We also saw models of service delivery shifting overnight to respond to the need in new ways. For example, at Unitas, what we did was we deployed rapid response networks in states and regions where there was no actual funder, but our data indicated there was a strong need. So really, what it did was identify gaps in access to social care. And here are just some notable trends. So since the onset of the pandemic, emergency food and rent and mortgage payment assistance have been the top two requested service needs. Among clients with known race and ethnicity, our data shows that these two services have accounted for a larger percentage of all service episodes for Black and Hispanic and Latino individuals than their white counterparts. And this, suggests that there is a higher level of need for these services across these different racial and ethnic groups. And then likewise on the ground, CBOs who are used to flexing and pivoting during emergencies did just that. These quotes here on the screen are from managers we interviewed at 2 different food banks in Florida about their experiences delivering care during the pandemic. And I'll let you all read the quotes, but the take-home message here really is that not only did community service providers have to get creative about how they met the need and increase capacity, but they also, the need has not gone down. The second quote here on the screen sums it up. They've seen a steady increase continue with no plateau yet. And this really indicates that we're going to be seeing the effect of the pandemic for years to come. And that's, no surprise to this group. And it'll be important for us to continue to collaborate across different sectors to really ensure that we're meeting people where they are at and getting them connected with the services that they need. So as we continue to build capacity, we know that there are a few things that work. One of those things is that CBOs like food banks that are embedded within the community and trusted, they play a really critical role in connecting people with additional services outside of their traditional roles. And in this example, the food bank manager we interviewed states that instead of just doing SNAP, they also help with Medicaid. This food bank manager says, we do taxes. We were helping people do their disability applications if they could not return to work because of conditions that were exacerbated by the pandemic. So really, as this person puts it, addressing these whole person needs is really the best strategy to shift from simply feeding the line to ending the line. And here, one example of how our system shifted to meet growing needs is shown in this graph on the screen. So using this example from North Carolina, one of our statewide networks, we see that referral volume increased drastically across the state from March, so kind of from that beginning point of the pandemic to the fall, so September, October-ish, which was during the height of the initial COVID surge. And perhaps one of the promising data trends here reflected is the 67% increase in network partners responding to referrals. So what this indicates is that increased capacity as service delivery had time to pivot and flex. CARES Act dollars flooded into local communities to really target community-based social care. All right, so let's again focus on one state network. What we looked at was social need resolution rates stratified by race ethnicity. And that first bar graph, what we see at the top is that that of all cases in this network between March and September of 2020, white individuals represented 44% of clients served, and Black individuals represented 41%. Now, looking at case resolution rates during that same time period, we see that the resolution rates didn't really vary much between racial groups, though the most successful service types varied by race. We see here supplemental food, clothing, and utility bill payment assistance represented the top resolved outcomes for Black clients, and then clothing, supplemental food, and household goods represented the top resolved outcomes for white clients. While we don't have data to really explain the reason behind these different top resolved outcomes by race, it is possible that these service types were likely already heavily embedded in those communities prior to COVID. Now let's zoom out to a longer time frame to get a better view of how things shifted and get an idea of continued needs and demographics served within this network. So this the same statewide network. We see that if we look at March through September March of 2020 through September of 2022, we see that Black individuals now comprise 70% of the total cases compared to 41% that we saw at the beginning of the pandemic. And white individuals represent only 21%. So this is a huge shift, and we can point to several upstream factors to really try to figure out why we're seeing these numbers. First, Black households' mean net worth is less than 15% of the average white household. What that means is that on average, Black families have fewer savings or alternate incomes such as home equity to draw upon when times really get rough. We also know that Black Americans share a disproportionate burden of chronic disease and other comorbidities, and that places them at higher risk for COVID complications. So really, and we've been discussing this throughout this research meeting, the upstream factors of structural and systemic racism, at least partially is responsible, right, for the increase in and continued disproportionate need for social care among Black individuals represented in these data. One bright spot to highlight here is the fact that along with the increased need, resolution rates also increase. So you see those 74 and 73% resolution rates for both, white and Black clients. And what that points to is that community capacity was sufficient to really resolve and meet their needs. So what have we learned? What we've learned is the importance of accurate and relevant data to really better understand diverse clients' needs and advance health equity. What we've also learned and what it gives us is that bigger picture of the role that enhanced technology and data infrastructure plays in advancing health-related policies and informing communities. And what we've learned is that we can work together to address racial equity by really collecting, accurate and complete data also. I'll wrap it up by just quickly looking forward. We're committed to centering individual and community voice in all our work, conducting impact evaluations. We are currently in the process of conducting and completing multiple evaluation activities, including process, outcome, and a few impact evaluations with different customers. We're committed to addressing real and SOGI data accuracy, so ensuring that our platform data capture meets evolving industry standards. We're actively identifying culturally relevant program needs. We're at different tables, whether it's advisory committees and thought leadership committees. And we're advocating for financial support and sustainability of CBO. So really, making sure that, funds are flowing into CBOs and really leveraging technology and data to demonstrate impact. So, making sure that they have the data and they can use the data to get more funding. I'll stop here. Thank you so much. And please feel free to get in touch if you have questions and drop your questions in the chat as well. And if you have any desire to discuss opportunities for collaboration as well. Thank you very much. I'll stop.
Thank you very much, Halima. Yeah, very interesting to see all this data as well from your database. Thank you. Excellent. So we'll move to the next presentation. As I mentioned at the beginning of the presentation, we'll do questions at the end. So now we'll invite Natalie Tedford to present. She's going to talk about social needs screening during pediatrics emergency department visits. And you have your screen up. Excellent. Go ahead, Natalie.
Thank you so much, Pablo, and thank you all for letting me be part of this conversation. I'm learning so much from you all. My name's Natalie Tedford. I'm a current pediatric emergency medicine and global health fellow at the University of Utah and work with Intermountain Healthcare at Primary Children's Hospital. And I'll be speaking to you about some of our initial social care work, social needs screening during pediatric emergency department visits, and language differences in reported needs. I don't have any disclosures, but I would like to recognize some of the support that we have had through community partnerships through the American Academy of Pediatrics, as well as ongoing funding that we're a part of through the NIH, with the principal investigator being nursery surgeon Andrea Wallace. And I'm sure, unsurprising to the group that's on the call right now, pediatric emergency departments do serve as part of that social safety net for families who lack consistent care, have limited English proficiency, and may have other social vulnerabilities. And as seen throughout the literature and work performed by other researchers, those on the call and others in the field of social needs research, ED visits have been shown to be opportunities to perform social needs screening and serve as an opportunity to link families to resources. We also know that language differences exist when we look at healthcare outcomes as well as social determinants of health and within the realm of social care. And so some of taking all of this and advice from previous studies in the literature and seeing gaps in our community health needs assessments, we decided to better understand unmet social needs in our pediatric ED patient population and the language differences that exist in reported social needs screening, so that we could provide better, inclusive, and more equitable practices as we move forward in addressing some of the social care work in our healthcare system. A little bit about our process to obtain some of this pilot information. We wanted to better understand, again, that prevalence in unmet social needs in our patient population, and we conducted a cross-sectional descriptive study at the Primary Children's Hospital in our ED during the months of April to August 2021. And we utilized research assistants who are undergraduate students enrolled and help provide enrollment to our various studies in the ED. And they approached a convenient sample of English and Spanish speaking caregivers of patients less than 18 years of age. We really emphasize these two languages, English and Spanish, more given that this was a pretty large comprehensive sample of our overall ED census, and given our limited funding at the time. We enrolled whenever a caregiver was enrolled, they were offered a pediatric version of the screener for intensifying community referrals for health, or the Sincere tool, and I'll highlight that in an upcoming slide. And again, given our limited funding, our kind of intervention at this stage of our work was utilizing United Way 211 resource cards, which felt not the best at the time, but thankfully has evolved as we've continued our work. In the caregiver's self-selected language, we then surveyed and assessed caregiver reported demographics, and then the 10 areas of social needs the tool addressed. And the primary outcome, again, was understanding that prevalence and examining the disparities and unmet social needs in self-selected language, as well as other patient demographics. And analyzed our data using chi-square and multi-logistic regression. This slide just highlights those adaptations to the Sincere tool that I was referring to. And as you can see here, those changes really are highlighted by the underlined verbiage in that to ensure that we had a child-centric screener that the caregiver filled out. And I also wanted to highlight that the Sincere tool had been initially created through collaboration through United Way of Utah and serve as a similar framework, at least for their process and intake for families who may seek 211 for resource navigation. And we ultimately felt that the screener was the most appropriate use, as our plans and current process include this community partnership with 211. Here, I know this is somewhat of a busy slide, so I'll just highlight a few portions, but during that 4-month period where we were collecting some of our baseline or pilot data, we had just over 10,100 patients who had been seen in our pediatric ED, and of those who were eligible, so spoke English or Spanish, and were less than 18, was about 97.7% of our patient population, so just under 10,000. And then, as you can see throughout the consort diagram, just highlighting those approached by our research assistants and those not approached. So obviously some limitations in our understanding of our patient population. And then here, I just wanted to highlight of those that were approached and provided our electronic screener to our English and Spanish speaking populations. It kind of came down to English speaking patients representing just about 90% and our Spanish speaking population representing about 10%, which again, pretty well mirrors our overall ED census demographics. However, when we look at those unmet social needs report, in our English speaking population, we saw 42% that, or 40% that reported one or more unmet need, while in our Spanish speaking caregivers, we saw greater than 70%. And for our whole screening population, it was about 42%. So obviously some fairly big disparities when we saw what was reported. Looking more specifically at some of the questions in our screener, for the most part, as you can see, it was more common for our Spanish-speaking caregivers to report yes and an unmet need on all items. Aside from, as you can see in number 1, which really addresses transportation, it was more in favor of our English-speaking caregivers, though we think that this is likely due to our much larger English-speaking population. However, when we see the decline to answer, which was also an option on our screener, we saw this interesting phenomena in which Spanish-speaking caregivers had a higher frequency of reporting decline to answer than our English-speaking caregivers. And this is really what's prompted us to understand further those language differences that we see in our screener and our patient population. I do wish that I had some more details regarding some of that, so I'll kind of briefly summarize the conclusions and talk about some of those next steps. But in conclusion, we did see, again, not surprising, that significant levels of unmet social needs exist in our pediatric ED patient population, which we were able to elevate and leverage in conversations with our healthcare system. And we saw disparities related to caregivers' language, racial and ethnic identities of the child from the caregiver reported, and also within insurance status. And we found that the differences existed in how English and Spanish-speaking caregivers responded to our social needs inquiries. Some of our next steps really are focusing on qualitative information with focus groups to see why some of these differences exist between our English and Spanish speaking caregivers, and also making sure that we appropriately validate the P-Sincere screener and the Spanish translated tool to ensure that those responses and what we're aiming to understand are appropriate. And then obviously our ongoing implementation work in our pediatric ED and as it relates to linking patient and families to community resources. This is just a brief references, and thank you. And it sounds like we will have questions at the end. So that's all that I have, and I'll stop sharing my screen.
Thank you, Natalie. Thank you for sharing your results. I can imagine it'd be very difficult to screen in the AD for peds. So we'll get some questions later on. Thank you. So we'll start with our last presentation. So presenting as a team, Mary Miller and Rachel Garg will present now, and they'll be sharing the screen now. Excellent. Yeah, that looks good.
All right, thank you. Hello, everyone. Thank you for having us. I'm Mary Miller, and I'm the Manager of Innovation on the 211 team at United Way Worldwide. So I support local 211 teams across the country. I'm joined today by Rachel Garg of Washington University in St. Louis. And so for our presentation today, I'll start off with a little bit of context about 211 and the network as a whole, and then I'll pass the mic over to Rachel to share more about data. All right, in case you are unfamiliar with 211, 211 is a 3-digit dialing code that connects a caller to a call center where they can receive specialized resources according to their needs. We have over 4,000 call specialists across the country, and they provide services in 29 languages. And so one thing we value about 211 is it is a free service for confidential help across a range of social services and needs. And consequently, we have a lot of data about what callers request, who calls, and where they call. And so the 211 network is comprised of over 200 separate organizations. So these might be located at United Ways, they might be nonprofits, sometimes they are state-run or government-run. They provide coverage for over 96% of the United States. We're working on Illinois, it's slowly growing. We're hoping for 100% very soon. As you can imagine, working with over 200 organizations to look at what data they have and what information they share is a complex and difficult process, but we've been building a national data platform to build a shared resource directory for all 211s. And so at the bottom, you can see kind of where we are at with that. So currently over 100,000 organizations are stored, but we are excited to have passed the 1 million mark for different services offered to communities. To give you a picture of how many calls we receive, I included our 15-year chart here. 211 is celebrating its 25th year in the country, but over time we have grown in that coverage area. So you can see a slight growth from expanding offering. Then we hit a bit of a decline, and then you can see a spike again during COVID times. I think it was 32 211s were activated by governors or their state health departments to serve as COVID-19 lines for their state. So we received a lot of calls related to that. 211s distributed over $32 million in resources related to COVID-19, so just direct financial assistance funding to communities. You'll see our latest 2021 data has us surpassing 21 million total contacts. And so 211, as we have grown, technology has also changed. And so now we provide text services, chat services, websites to connect people to resources that they need. And so local 211s engage in research in a variety of ways. I intentionally titled this presentation 211 like possibilities for research, because I think we're doing it in all sorts of ways. But I feel like 211 data is a rich and untapped resource in some other research potentials. And so I wanted to highlight what some local teams are doing. They might look at caller needs, they might look at resource gaps. We saw an analysis of food deserts in the greater Twin Cities area. There's a lot going on in a lot of 211s. We would love to invite you to take part of it. But to look closer at the data and from a research perspective, I'm going to pass the mic over to Rachel.
Hello, everyone. I'm Rachel Garg, and I work at the Health Communication Research Laboratory at Washington University. Starting in 2014, our research lab created a system called 211 Counts, which is an online data dashboard and data repository for requests that are made to 211 helplines. Every day, 211 Counts is updated with new data that tracks requests to 211 helplines around the country from the prior day. On the dashboard, which is available at 211counts.org, it's possible to view and search requests with very specific detail down to the day that a request was made, the zip code that it was made from, and the type of service that was requested. So we think that this is perhaps the best population level surveillance system of social needs in the United States. Next slide. Since we have access to this amazing data resource, when the pandemic started in 2020, we created a spinoff that we called Focus 19, where we published short reports that analyzed 211 data to try to track the social and economic impact of the COVID-19 pandemic. Over the course of about 1 year, we published over 120 different reports on 211 data and the COVID-19 pandemic. And I want to briefly share with you 3 of those reports today. Next slide, please. So one of the challenges of working with 211 data to understand racial health disparities, at least data from 211 Counts, is that these data usually are not linked to demographic data. So generally for each 211 request that's tracked in 211 Counts, we only have information available on the type of request that was made. So this could be something like looking for a food pantry or requesting help with rent payments. Then we have information on the day that the request was made, and then the zip code that the request originated from. So what we generally do is we link 211 data with census population estimates by zip code to try to understand more about the demographic makeup of the communities from which 211 calls are originating. So in this first report that I'm sharing, we tried to find population estimates for 23 different groups that the NIH designated as health disparity populations, or as groups that were particularly vulnerable to COVID-19. And we found that most of these groups were overrepresented among 211 callers. And these groups included racial and ethnic minorities, people who are socioeconomically disadvantaged, and those with medical comorbidities or mental illnesses. Next slide, please. We used a similar approach in this next report that I'm sharing, where we linked 211 data to census population estimates for the Hispanic population in Washington state. In the bottom left map on this slide, darker blue shades indicate a higher concentration of Hispanic population in Washington. In the map on the right, orange represents regions where there were increases in calls about COVID-19 testing to the 211 helpline, while blue regions indicate areas where calls to 211 helpline about COVID-19 testing either decreased or remained about the same over time. As you can see, the regions where we saw increases in requests about 211 calls significantly overlaps with regions where there's a larger proportion of Hispanic populations. When we shared these findings with the director of 211 in Washington state, he stated that this aligned with what they were seeing in terms of infection rates in central Washington, where there's a large migrant worker population. Next slide, please. This is the final short report that I wanted to share. And in this report, instead of linking 211 data to census estimates, we linked it to data on eviction filings that are available from the eviction lab at Princeton. So this analysis was conducted using 211 data and eviction filing data from Milwaukee. In the map on the left, darker orange indicates higher numbers of eviction filings, and in the map on the right, darker blue indicates more requests for rent assistance to 211. And you can see these maps look very similar. We track these trends over time, and you can see in the chart on the bottom of the slide where date is indicated on the x-axis, and it ranges from about January 2020 through June 2020. The orange line is number of eviction filings during that time period, and the blue line is number of requests for rent assistance. As you can see, both requests for rent assistance and eviction filings decreased during a temporary eviction ban, which is indicated by the gray shaded area on the chart. But as the end of the eviction ban drew closer, requests for assistance with rent assistance again started increasing, and a few weeks later, eviction filings also increased, following a very similar pattern. So what we concluded from this analysis was that 211 requests are a very good leading indicator of eviction filings in communities. Next slide, please. We think that promising future directions for research with 211 data include linking 211 data with other data sources, such as the census data, and doing geographic analyses to understand disparities. We also think that it's important to look at how trends in 211 requests change over time. And this approach can be used to evaluate policies such as eviction bans or other community level interventions to understand how they impact disparities in social needs. Thank you.
Excellent. Thank you, Rachel. Very exciting to see how you can really use this data. So thank you for the panelists for the presentations. Right now, we're going to get Sharon to give us first impressions about these three really important ways of using this data and showing the health-related social needs. Sharon, go ahead.
So hello, everybody. I'm Sharon Alexander, and I'm what they call the expert by experience. I'm a patient, and I have been affected in some way by the social services that have been discussed here, or the lack thereof. I'll be, my birthday is in next week, and I'll be 70 years old. So I've been around the block for a minute, and I have varied experiences, not only for myself, but for my family members, as well as my mother who passed on. But I really appreciated listening and hearing about the various tools that are available. I think Halima, who mentioned a tool that is available for a technology platform that helps to make a distinction or identify data, refine data rather, in ways that makes it very, very useful. And also Natalie mentioned the Sincere tool, sounds that screeners can use, and offered some things that screeners ought to be able to consider, or what they need to consider in training screeners to use it more effectively. But it sounds like a really great tool in terms of what it provides. and then listen to Mary and Rachel talking about the history of the 211. And it does appear to be a really great source of data. And then they did recognize or pointed out that there was some deficiency in that certain of the data cannot be segregated in certain ways, but they're probably looking to ways to make it more effective from a demographic perspective. But it all sounds very good to me. I just wanted to also stress that I can't stress enough the importance to include the perspectives of people like myself, the people, patients and people who are down in the trenches with direct hands-on knowledge about the different aspects of the research topics. There are a number of different ways that we can be used to provide and to help make the data come alive, to help keep the researchers on track, to partner with the researchers. That's really kind of why I'm here today, to just make those kinds of statements. And I'll close by basically saying that I've participated in numerous focus advisory and other information gathering groups for the past 6 months, helping researchers appreciate the lived racial experiences of African American people quantified in these research projects referenced throughout today and throughout the symposiums. And I'm here to encourage researchers, and that's what I want to do, to work hard and help accurately apply a racial equity lens to social care research data and practice, with an end goal of strengthening the health equity impacts of social care. I can't tell you how important that is for us to have a arm-to-arm relationship as we tackle these problems that can make it more meaningful to all of us that are concerned. Thank you.
Sharon, thank you very much for your reflections there. I think it really highlights how important it is to really do these interventions with the community and engage in the community, and not really for the community, because we really fall short, and the importance of bringing people in while we develop these things and these interventions, and really applying a whole equity lens and really thinking about, right, are we really closing disparities here? Thank you for sharing that. So we'll open it to questions from the participants. Either you can use their reactions and raise your hand, or feel free to unmute yourself if you have any question that you want to ask the panelists. Janice, go ahead.
Hi, my name is Janice Tupke, and I'm an individual with lived experience and have been pretty steeped in socially determined health research, quality improvement for a decade and plus now, and my own community projects I started a couple decades ago. So I just wanted to say that I thought it was interesting about, I think it was 211, and how the calls went down in 219. And I'm kind of surmising here, but I'm thinking it's because of the advent or broader scaling of like Aunt Bertha, Unitas, Find Help, and that perhaps is why 211 was used less, is because they also offer, working with, especially with the FQHCs and more. So I'm curious if, and then of course during COVID, it was everybody, right? I mean, and I'm curious if you think that might have some impact.
That's a great insight, Janice. We haven't looked at it from my side on the cause of it, but I'm going to take that back to our team and ask around and see what the consensus might be, because I could absolutely see, as more resources become available, people look in different places, people connect, and especially with technology tools making easier access to resources or help. I mean, that's always a good thing, but you're totally right about COVID-19. It became all hands on deck for everyone, and you can see it reflected in the data with just the sheer number of calls you're getting.
I appreciate that. And I've been making resource guides for decades. I was one of 3 women that started for the unhoused in Seattle back in 1996. So I was one of the first people to add when 211 came out. I was very excited about it. So I appreciate your work. And I just have one thing that we hear from everybody is the waiting line is very long, right? So, and we all know this, it can be hours sometime. And the reality is that it's just something that clients and patients should be aware of, right? So that there's a lot of people competing for resources right now. And thank you.
Thank you.
Thank you, Janice. Any other questions from the for the panelists? One thing that I think it's interesting, and I would like to give the opportunity to the panelists to ask, reflecting on what Sharon mentioned. Can you share, like, with respect of either your technologies or your programs, or in this case for the pediatric emergency, can you briefly share what was your approach on including the community in terms of how you design and develop these different tools to support? If that's okay, Halima, do you wanna start? If you have some comments about that.
Yeah, absolutely. So as I mentioned, we are in the process of concluding a few evaluations that also includes a heavy, process evaluation approach. And that's where we gather input about the technology, how it's working for the end users, people who are actually using the technology. And we're also in the process of gathering information from at some point in the future from clients as well. So people who are benefiting from the referrals, who are being referred to the services that they need. So we're actively engaging the people that are, using the technology to make sure that, if there are opportunities for optimizing the tool and making it even more useful for people, that we're doing that. So definitely engaging the community.
Thank you. Mary, Rachel?
Sure, I can talk a little bit more about what our research team does. We have a lot of research projects where we enroll participants that after they have called 211 and ask if they'd be interested in participating in our studies. And so we contact participants that way. And I think one of the ways that we've engaged community members who have called 211 that I'm most excited about is one of our projects that we call Life During COVID. So we enrolled in a study 60 women with children who were either employed or looking for work, and we sent them mobile phone surveys every 3 days for about 1.5 years during the pandemic to collect information on their social needs and other aspects of their life that might be changing during the pandemic. So that was a really great way for us to engage with the community, and we're learning so much from that data about just how much social needs can vary day to day. And we've applied for funding. Hopefully we'll be able to talk more with these participants and do qualitative interviews to discuss the information that they've shared with us and to be able to really understand more about their experiences of social needs during the pandemic. So I think those are some of the ways that I'm most excited about how we've been engaging and learning with community members.
Thank you, Rachel. And Natalie, can you briefly share what you guys have done?
Yeah, just from that standpoint, we are utilizing, again, kind of emphasis on focus group and getting information from our patients regarding this so that there is that exchange. And as we kind of navigate some of these other areas of information exchange, that's another piece that we want to make sure that we're prioritizing the desires of the families and the patients that we serve, whether that's part of their healthcare system or healthcare record or not, and ensuring that this is something that they would like to be asked in a visit or not.
Thank you, Natalie. So we are at, it's 2 p.m. So we're at the top of the hour. I really want to thank the panelists for presenting and really reflecting on what Sharon has also shared. It's really important. I think it's been great to hear from everyone please feel free to reach out and really share your reflections on anything that came up from this. So I think to close, one interesting thing that I recently saw that goes to Danny's comment, I've seen some efforts of starting to use blockchain technology, mainly like with Bitcoin users, to try to do this, but I haven't seen them spread. But I think that's something interesting that I've learned too. So thank you so much, everyone. I think it's been very exciting to hear from everyone, and thank you for sharing your work, and have a good rest of your day.